So I entitled my talk, I was asked to talk about designing for the future healthcare professional, reframing, retooling, and retraining is what I've decided to have as a tagline. So I very much want to thank you for inviting me here. I've enjoyed Venice the previous 2 days, and it's a great place to be. But I do wear 2 hats. I have been implementing or leading the implementation of interprofessional education and collaborative practice at the University of Minnesota for the last 15 years. And yes, it takes a long time. We were awarded in 2012 the National Center for Interprofessional Practice and Education. And I have to say the acceleration in the United States of healthcare reform is definitely accelerating the thinking around health professions education. One point I want to make is we're investing a lot in the US in healthcare reform. CMMI is great, but virtually nothing is being invested in workforce development. So that'll be a theme that you'll hear me talk about today. So this is the National Center's vision. We believe high-functioning teams can improve the experience, outcomes, and costs of healthcare. And yes, that is the adapted Institute for Healthcare Improvement's triple aim. And the National Center is studying and advancing the way stakeholders in health work and learn together. And we intentionally did not say teams of physicians, pharmacists, nurses, and the like, but want to be very much inclusive of the patient, families, and communities as members of the team. These are the National Center's funders. Again, it was a competitive process. We are a cooperative agreement with the U.S. Department of Health and the Health Resources and Services Administration. And so it was a funding opportunity announcement, but what has made this a historic national center is that previous to the award, these 4 private foundations also have been funding the National Center. So these 5 funders saw at the time, 2012, and that's an important date, I'll go back to that it was time for a national coordinating center for interprofessional education and collaborative practice. So these are what I think are the important themes today. And you've heard about the significant redesign thinking and realignment of the relationship. And I talk about US because we are a national US center, but there's certainly implications globally for the healthcare delivery and education around interprofessional teamwork. So there's no question that the redesign of healthcare is impacting the thinking in health professions education. You heard already that there's a shift of focus away from the professional-centric to people, patients, families, and communities, and it is happening around the social determinants of health. And I have to say, yes, we in the United States have a lot to learn, particularly from developing countries, but we are starting to see a lot of redesign around the social determinants of health. I'm going to talk a little bit about the renewed interest in a 50-year-old field of IPE, interprofessional education, and a little bit about the approach of our National Center for Interprofessional Practice and Education. I always start every talk that I give with the definition of interprofessional education because it's a term that's thrown around pretty loosely these days. And it came from the Center for the Advancement of Interprofessional Education in the UK in 1987. And yes, the World Health Organization adapted it in 2010. So IPE, interprofessional education, occurs when 2 or more professions or students and professions learn with, about, and from each other to enable effective collaboration and improve health outcomes. So it is a methodology. It is about learning with, about, and from each other, and very specifically and intentionally to enable collaboration and to focus on health outcomes. WHO defined interprofessional collaborative practice. It occurs when multiple health workers from different professional backgrounds provide comprehensive health services by working with patients, their families, caregivers, and communities to deliver the highest quality of care across settings. And in red, the National Center puts and pre-licensure and qualified learners. So students and residents, we think, are absolutely essential. Because in the United States, what's happening today is with the transformation of healthcare, and you've already heard the stressors on health systems and professionals, many health systems are getting out of the teaching business. So at a time when we're expanding, and in the United States, it's much more than medical schools. It's pharmacy schools, nursing schools, physician's assistant schools. As we're expanding the number of schools and students we're training, the health systems are actually decreasing their teaching. So even getting access to clinical rotations is becoming a problem in the United States. So this is the framework, and I cannot agree more. We need to focus first and foremost on the outcomes of what we're all about, so that patients, families, and communities, and the triple aim. Again, improve the patient experience of care, improve the health of populations, and reduce the per capita cost of healthcare simultaneously. And the cost factor is always controversial. So some say adding value, some say appropriately resourcing, but the big issue is paying attention to costs of healthcare and resourcing. So you heard also the current workforce is how do we create a workforce in the right locations, specialties, and practice settings that has the skills and competencies needed to meet the demands of a transformed healthcare system while preventing burnout. And in the United States, that's called the quadruple aim, because the stress on our current clinicians' workforce is substantial. And then taking us back to the learner pipeline is how do we prepare the next generation of health professions for a transformed healthcare system while improving experience of learners and decreasing costs. Because in the United States, our students, because the government and the state governors are getting out of the business of financing health professions education, we are actually increasing tuitions substantially, and our students are graduating with astronomical debt loads, and it is having an impact on the healthcare delivery system. So the message that we in the National Center send, it's not just about reducing costs or the triple aim in healthcare, but it's the triple aim of alignment between health professions education and the delivery system. So this is the 50-year-old field in IPE. It's not a new field, it's hot today, but there were many of us who worked decades in the field, thought in the United States it was dead in 2006. So it really was introduced to the United States in 1972 by the IOM. We have this document on our website, and if you read it, it reads just like today, except for there's not a she or a woman in the report, but it reads just like today. In 1977, in the United States, the word interprofessional was used for the first time. And this is at ACGME, Eric. I went to Bud Baldwin, who's a pioneer in interprofessional education's office, still researching at 94, and I have got all of the history of IPE I took out of his office, and it's been digitalized. But again, if you read these documents, just as relevant today. 1987, as I alluded to, the CAPE, which is in the UK, was formed, and it's still highly influential today. We've alluded to what I call the IOM trilogy, To Err is Human, Crossing the Quality Chasm, that laid the ills of the U.S. healthcare delivery system at the foot of health professions education and was picked up by the Bridge to Quality. You've heard about the Lancet report, but very important in the United States was the yellow document, yellow-orange document, which is the Interprofessional Education Collaborative. So 6 professions, the Association of American Medical Colleges, the American Association of Colleges of Osteopathic Medicine, the American Association of Colleges of Nursing and Pharmacy, that's 2 organizations, the American Dental Education Association, and the Association of Schools and Programs of Public Health, very historic, came together in consensus for core competencies for interprofessional collaborative practice. And here they are. And so these have been the marching orders for these 6 organizations, but now that's been expanded to 9 more, inclusive of veterinary medicine, occupational therapy, physical therapy, social work, and others, coming together and aligning around these competencies. And the Global Forum in Innovation in Health Professions Education, convened by the National Academy of Medicine, is having a huge impact on the United States. Last week, for 2 days, the accreditation agencies in the United States met and are talking about how do we come together and align accreditation in the United States. So, what is the evidence that IPE is the right approach? Very little. In last year, exactly 1 year ago, a report was released by the IOM on measuring the impact of interprofessional education and collaborative practice and patient outcomes. I served on that committee. It was intense. It was chaired by Malcolm Cox, who had been the lead in our Veterans Affairs academic health system, and Scott Reeves, who is the editor of the Journal for Interprofessional Care, Brenda Zerler at the University of Washington, and others served on this committee. We looked at all of the literature again, and the evidence is scant that doing all this in interprofessional education makes a difference, certainly on patient and health outcomes. There's a reason for this. First of all, it's hard to research and evaluate what you haven't done. And number 2, the quality of research in this area has not been rigorous. So we developed a model, which is in this report. We put all the evidence that we could find and made bold recommendations. Couldn't agree with you more that the science and research behind this work is imperative. So one of the controversies over the years has been, when do you start interprofessional education? And we at the University of Minnesota started from day 1. We require 1,000 students on 3 campuses to take an entry-level course, and then we work with faculty to integrate it into their curriculum. But that's been very controversial. Do you start it before professionals know their own identity, or do you start it from day 1? We on this committee said from day 1, but we recognize that most of the efforts in IPE have been in the classroom. And so the majority of the efforts today occur early in the learning curriculum, what we called foundational education. And by the way, coming up with the common language of what we call the various education across the professions is quite challenging. But when you start it at that lower level and don't pick up on it, it tends to have lower learning outcomes, meaning you may have an impact on attitudes or perceptions. And then we said that the greatest opportunity for collaborative practice is when students and trainees are working together in clinical practice where relationships are formed. And if the ultimate goal of all of this work, teamwork, interprofessional work, is to improve health and systems outcomes, education and training should actually increase across the learning curriculum. So into graduate medical education, into continuing professional development. And at best, there's a weak connection between classroom IPE and health outcomes. I often give these talks and people stand up and say, well, we haven't been able to prove that medical education has an impact yet. And I tell people, but in IPE, as we're changing structures and thinking, there's a greater burden on us to present the evidence. So we on the committee actually call this the reverse megaphone, meaning, yes, we need to increase this methodology into practice, into graduate medical education into practice as we go. So a little bit about the National Center. When we applied in 2012, we were actually experiencing something in Minnesota. In 2008, the state passed healthcare reform, which predated the federal reform. And the health systems, we've implemented patient-centered medical homes, now accountable care organizations and the like. And the health systems in Minnesota were telling the academic health center at the University of Minnesota that it takes too long to retrain graduates of the University of Minnesota. That was a stake in the heart because we had been implementing IPE for nearly 10 years at that time. But we were able to come together in what we now call a courageous conversation and point out to the health systems that, you know, our students spend their last 2 years in your health systems. Why do you think they're not prepared? And what we were able to do is come together in a more robust partnership between classroom, education, and the health systems to redesign our work together. So we gave the proposal to HRSA that what we call is the nexus, and we do call it that and want people to stop and say, what is that? Because we want people to think of a different partnership between education and practice, one that's focused on improving the triple aim in both health systems and in education at the same time. So we do call this the triple aim of alignment, improving the quality and experience for patients, families, and communities and learners at the same time, sharing responsibilities for achieving health outcomes and improved learning at the same time, and reducing cost and adding value in healthcare delivery and education. As an administrator at the University of Minnesota, where our budgets are declining, it is imperative that we as academic leaders also have the conversation about the cost of education in addition to focusing on learning and outcomes. We have a research network that's growing across the United States. We call it the Nexus Innovations Network, and it links practice and education. We use comparative effectiveness research, and we're collecting data across the United States in a national center data repository. We have many advisors that come to Minnesota to advise us on this approach, and we have implementation support, and we use it as actionable measurement. So the states that are in blue are various stages of implementation. The states that are outlined in red is a 41 grantee program of the Health Resources and Services Administration. And these are nurse practitioner-led grantees. And we're collecting the same data in these grants as we are in our innovations network. We were chosen by the Robert Wood Johnson Foundation to pick up the future of nursing work, and we have an RFP out now in the United States to give nursing schools funding for interprofessional community-based practice. They realized that they never got to the interprofessional part of the 2010 Future of Nursing report. This is what we affectionately call the snake, or the onboarding pathway. We know how to take people through these process and think about implementing IPE in the community, but more importantly, how are you going to standardize and collect data across our sites? We have this fully implemented with software so that we can manage and know where our sites are at any one period of time. And this is an example of, and again, We do not use randomized controlled trials. We use comparative effectiveness research. We have quite a number of publications that are out now. We did choose high impact factor journals because we felt it was very, very important to have peer review and scientific eyes on our work. So we sit down with these various programs, and we take them through a work plan. We take them through what they're focusing on, a research question. At the University of Kansas, they have a program that we actually helped develop called Preceptors in the Nexus. It's a faculty development program training clinicians how to teach, not just students, but teach each other as health professionals about interprofessional collaboration. They are testing this program not just on the learning, but on the potential impact on health outcomes in two areas. One is on diabetes, and the other is on obesity. And we have several of these projects going on because, as you'll hear later, we in the United States are working on what could potentially students and residents do to actually add value to the delivery system as teams. So we go in, we teach teamwork to clinicians, students, and residents. We have some of our sites that have full cycle of data now and are getting ready to publish their own work. So this is our website. We have a lot of experience with open access. We chose to have freely shared resources. There is no peer-reviewed. There is a peer-reviewed mechanism in the United States. AAMC has the MedEd portal. And for many, many faculty, they absolutely need that type of peer review because the memo hasn't gotten down to many of the universities yet about the importance of open access and sharing and dialogue. And so you are recommended to freely look at our site. We can talk very much about how we can align and link, and I would be more than happy to share our experiences in this realm. I might say that the Preceptors in the Nexus program is freely available. Over 8,000 people have now used that program on the website. So we're going to have our very first meeting, and the dates are August the 21st and 23rd in Minnesota. And it is going to be a dialogue program around what we consider to be the two burning IPE issues today. The first one is, how do you resource interprofessional practice and education in an era of new payment models while we're decreasing costs and adding value? There are three areas. We get a lot of calls in the National Center now because IPE is being written into accreditation standards. I'm not sure the accreditors know exactly what that means yet. But we get, for example, 1 week we got 4 Research One universities contacting us about how should we organize, what kind of office should we open up, what type of resourcing. You know, another area we'll be discussing is the resourcing of IPE. The Macy Foundation only has so much money. At some point, it has to be an internal funding. And then we'll have another focus, as we do have several schools now that have been able to demonstrate adding value to the delivery system by student teams, and they've been able to talk to their Medicaid or funding for underserved populations in each of the state or Blue Cross Blue Shield to actually fund education. So we need to get to that level of commitment between education and practice. And then the second issue is new models of care require new models of learning. Are we ready to think and act differently through approaches to IPE? And so we will have the joint accreditors of interprofessional continuing education, which is a new mechanism for accrediting CE, continuing education in the United States. We'll be leading one of those conversations. And then we will also be talking about what should the criteria be for standards in IPE. Because today, individual accreditors are writing it in, but there's no common understanding about what they're looking for. And so while pharmacy has written 11 of their 25 standards has interprofessional education in it, they have to collaborate with all the other professions. And so it makes implementation right now rather challenging. So we'll be having that conversation also at the summit. So I invite you to explore our work in the National Center, and I very much look forward to continuing the conversation with you and how we can contribute to the global efforts. Thank you.